And for those who didn't get to fill out the pre-survey, we do have it in the chat, so feel free to go and access it there. I'll hand things over to Otto.
Well, good morning, everyone. Welcome to our third module, which is the discharge and transition planning. It's great to see everyone here. Looks like we've got 22 people so far at our education today. And before we begin, I'd like to acknowledge, do our land acknowledgement that we acknowledge we operate on the traditional, ancestral, and unceded territory of the Coast Salish people, the Musqueam, Squamish, and Tsleil-Waututh nations, and we are grateful to be here. So some of you might already be familiar with the Missing Middle program, which began in 2022, engaging with different groups to understand more about the Missing Middle. The Missing Middle program is a multidisciplinary team aimed at improving the service experiences of 16 to 24-year-olds with moderate mental health and substance use concerns and their families. The goal of the Stephanie, Sarah, and myself is to build healthcare providers' capacity and understanding of this population through consultation and education. So that's why we're here today. And our hope is that our education will ease the transition process for young people as they go through their developmental and mental health journey. So we have a number of learning objectives today, which is around discharge planning and transition planning. The first one is to identify the key elements of a discharge plan, including participants, to describe the components of an effective safety plan, to demonstrate understanding and the importance of patient and family-centered care, so specifically youth-centered care, and how this applies to discharge planning and safety planning. Identify the key elements of an effective transition plan, including transition between services or transition from child and youth to adult services. To demonstrate understanding the importance of patient and family-centered care and how this applies to transition planning. To discuss how to seek out and develop resource lists to support your practice, and we'll talk a bit more about that at the end. And to review key resources around transitioning and supporting emerging adults 16 to 24. We also acknowledge that many of you have had experience and wisdom and knowledge around discharge and transition planning. So part of what we really enjoy is to hear part of your practice experience and learned wisdom around working with youth and their families. So to begin, we just wanted to do what we call a chat blast. So the question for the group is, what are some of the challenges you might have faced during discharge planning? So if everyone can consider that question for a moment and write in the chat what some of your thoughts are around challenges you might have faced during discharge planning. And we'll take a few minutes for this.
And what we'll do here is what's called a chat storm. So before you send your answer in, just feel free to type it out and not hit send yet. We'll give everyone about 20 seconds. And then when we say go, we'll all send those responses in so it comes in a storm.
Right. Sorry, Sarah. I was going for the chat blast right away.
So we'll give another 10 seconds or so for people to type out their answers and get them ready. Okay, feel free to hit send.
Okay, here comes the blast. So wait lists to services, absolutely. Communication disconnect between care team and the young person's support network, absolutely. And we'll talk a bit more about that. And certainly there are challenges. Lack of resources to refer to, GP shortages, wait lists, lack of communication between teams, not knowing all the contacts, not having the correct contact information, delays in meeting being held, caregivers not being involved in care early enough, providing a connection to low-cost community resources, and again, wait lists for sure. Let's just give it another minute to see if there's any other. So definitely there are themes. And this is another good one, lack of trust from youth to services. So many of you have identified what are some common challenges around discharge planning, particularly for youth, young adults and their families and the service provider. So time is the essential one. And sometimes, as many of you experience, that discharge can happen fast based on discharge that only gives you a few days. And so time is always a consideration. Patient not feeling ready or prepared. Resource barriers, and many of you pointed that out, wait lists, exclusion criteria, paperwork that are required, mandates and capacity, family in disagreement with the plan. Sometimes it might be team members who might have this differences in the treatment plan, limited or no access to appropriate services, complex case that have multiple barriers such as housing, financial, and physical health concerns, difficulty engaging patient and discharge planning, language barriers, systemic barriers, and such as staffing or funding, and limited or lack of insight, which might limit their participation or agreement. So many of you have identified these common themes. There's also another chat which talks about the lack of services to discharge in the adult world. And this is definitely some of the things we looked at in our transition surveys, where they look very different in terms of level of support and keeping on the caseloads. So yeah, well done everyone for identifying all the themes. So why does effective discharge planning matter? And all of us has had experience around discharge planning. Receiving mental health treatment in the community allows the youth to continue their psychosocial development, educational achievement, and family and peer relationships. Really, it's really the importance of the recovery. Effective and established discharge planning guidelines can reduce staff, patient, and family distress, improve patient flow and wait times. And a shared goal that we have is to reduce the rate of readmission, reduce complications and safety concerns after a discharge, ensure patients are connected to the most appropriate resources, and to set patients up for success with the next service. Especially for youth and young adults, is we really want to have a positive imprint of support and services they experience. So when we look at discharge planning in terms of patient and family-centered discharge planning, there is a hub where we start right from admission, and it's that old adage, discharge planning starts from day one, and all of us have experienced very complicated and complex cases, involvement of key interested parties, education and resource connection, safety planning, and we'll go into some of these in more detail, clear and ongoing communication, and the challenge is to really focus on patient goals and expectations, as well as family goals and expectations. So many of you have experienced and identified the key elements of a discharge plan. So we know in our healthcare system, there's definitely challenges. There's a revolving door effect due to systemic challenges and the acuity and the chronicity of patient presentations. Despite these challenges, there are some ways healthcare providers can provide and ensure a safe and successful discharge. One is to initiate discharge planning conversations with the client and team right from the moment of intake, and to really acknowledge what their goals are, what their plans are, and what their needs are. To understand all the participants in the discharge plan and what their perspectives and goals are around discharge, that patient, client, current healthcare team, primary care provider, whether it's a GP or an NP or counselor, family or chosen family, and future healthcare team and other people involved. And the last key element is to ensure communication is easy to understand, consistent, and ongoing for all participants. Understanding the preferred method of communications for participants. Ensuring that client and family-centered education is a key focus of discharge planning. And part of this is really for them to ask questions and really to repeat information as we go through the discharge process. To discuss the patient and client's expectations and goals for discharge, and to identify any discrepancies, working with participants to solve, compromise, or adjust expectation or goals. And sometimes, as you know, this could be wait lists, this could be finding their appropriate resources or lack of. And some of these might require creative solutions and collaboration. So starting with the patient or client, we know from conversations with patients and clients and care outcomes that a discharge plan is more successful if the person being discharged is included in these conversations. So not only just the process of communicating the discharge plan, but also having buy-in. And we know motivation is a really valuable currency in care planning. When you can include a patient in the discharge plan, understanding the patient support networks and how they want them included, this is particularly important for youth and young adults. And we understand the value and importance of peer networks. To understand the patient's expectations for care, sometimes we have to have a realistic conversation about what their expectations might be as well, to discuss the patient's goals for treatment, and to understand the patient's wishes for the next step in care and discharge follow-up. And then with the current healthcare team, the current healthcare team is most often responsible for ensuring communication with participants involved in the discharge plan. The role of the current healthcare team is to let participants know the expected length of stay, and sometimes that's hard when there's an ongoing assessment or medication titration or other goals of treatment. Ensuring messaging is consistent among team members, and we've all experienced sometimes there might be a split when there's different messaging. Discussing the goals of treatment and roles of the team members in treatment so that the patient and family have really clear understanding of what we all do. Working with the patient if there's discrepancies in goals. Ensuring resource connection or plan post-discharge. And as mentioned earlier, assessing the level of motivation throughout each step. And primary and future providers, primary care providers such as GP, NP, counselors are the most consistent providers in a patient's healthcare journey, especially when we think about the missing middle, youth and young adults, where they might not be with an adult mental health team, but they are reliant on primary care providers and community resources such as counselors to ensure consent is received for communication. It's also important to include them in any changes to care around medications or treatment with the client's consent. Sometimes it might be just the pacing of appointments. Notify them of any risk or concerns around self-harm, suicidality, disordered eating, depression, psychosis, or other concerns. Provide detailed follow-up recommendations in discharge consultation and documentation, really ensuring that the plan is communicated throughout, ensuring discharge consultation received by the primary care provider, and ensure follow-up recommendations are appropriate for the provider. So there might be some things they can or cannot do. And the receiving team, when possible, around discharge planning is similar process to the primary care providers and future providers. It's a similar process when discharging back to an existing team. Engaging the clinicians and case managers in discharge planning will create a more effective and sustainable transition. And we know one of the challenges is to actually get the person by phone or if they're able to come in. And part of the challenge for all of us is time management and actually having accessibility to people. When discharging to a new team, connect to share any handover that might be relevant for patient care.
Awesome. Thanks, Otto. So now we're going to move into safety planning. So this is a pretty key element of discharge and or transition planning. So we do want to ensure that this is covered as a concept of both of those. So some of the key elements in an effective safety plan are identifying any current stressors or triggers. So that could look like certain situations, certain places, but also making sure that it's specific. So for example, when working with teenagers, sometimes they'll tell me, oh, well, home is like my stressor. And so it's like, what aspect of home? Because obviously you're living at home, so we can't necessarily remove that entire stressor, but is there certain aspects, when people are arguing or when doors are slammed, things like that. So trying to be specific with the stressors and triggers. Early warning signs of stress. In our previous module, which was family-centered care, we talked about the importance of including family and chosen family. And so when we're talking about these early warning signs, often your family members can be a key person to ask these questions, because when we're really in it and we're feeling stressed or anxious or worked up, or we're completely dysregulated, sometimes we're not able to identify those early warning signs. But if you talk to family members, they might tell you, oh, I noticed that they go really quiet and they don't want to be around people, or they start clenching their fists and I know that something's going to happen. So it's really important to include that family, caregivers, chosen family in these conversations to identify these things. And what coping strategies they currently have. If it's a young person, it is very possible that they might not have identified any coping strategies. Those are things that have to be learned or taught. And so that might be a question like, what have you learned? What is working for you? If there isn't anything, that's maybe something to talk about, especially in your setting. Obviously, recognizing I work in the emergency department, I'm not necessarily able to teach somebody a coping skill right away, but there are certain skills that we can teach in a shorter time frame as well that might be helpful as a takeaway. Another important element is who your trusted contacts are. So for the purpose of things like ensuring that somebody is a responsible adult who's going to make the right decision and call 911 or ensure that somebody reaches out, we do want to make sure that majority of the people on that list are adults. Can young people have their friends on that list or partners? Yes, that's definitely encouraged. But we do want to ensure, especially when you're talking about a 16, 17-year-old, is their friend going to call 911 if they're voicing suicidal ideation? If that's a concern for them, we do want to make sure that there's an adult on that list, because we don't want it to be kept a secret. We want to make sure that everybody's safe. Also identifying community mental health and substance use support. So if they're not connected to any services, they don't have a family doctor, that looks very different than somebody who possibly already is connected to maybe a crisis team, a counselor, an MCFD social worker. So we want to make sure that that contact is clearly laid out as a person that they can contact during the hours that they're available. Majority of safety plans that I've seen in the Lower Mainland always include crisis line information. So if it is something where your program is looking to develop a safety plan, always making sure that crisis line contacts are available on there. In the later section of this presentation, we'll go through resources, and some of the common crisis lines are located on there. And then a plan to do when you're feeling unsafe. So this can look really different for each person depending on what the reason for the safety plan is. Is their safety plan related to suicidality? Is it related to psychosis? Is it related to substance use? All of these are great reasons to complete a safety plan, but what do you do when you're feeling unsafe? So making sure that's very clear, because when someone is either like extremely anxious or worried or going through a psychotic episode, it needs to be clearly laid out, because having something and not understanding what the steps are might be really difficult for them when they are feeling worried or anxious. 911 or hospital is always an option. Majority of emergency departments in the Lower Mainland and in BC are, for the most part, open 24 hours. And so that's really the number one place to be sending people if they are feeling unsafe or they're concerned about hurting themselves or hurting other people. And then also guardrails in place. So what is a protective element for them? So what is keeping them here, and making sure that we're focusing on that strengths-based approach. So what is a protective factor for you? Is it your family? Is it your pet? Is it your friends? Or maybe you have a musical theater presentation and you have a show next week. Like, what are the things that are keeping you here, and really highlighting those when you're doing a safety plan. So safety plans should be completed with the patient and any family that I identify. So sometimes when I'm completing safety plans, I may, if the patient or client wants to complete it by themselves, I'll always encourage, can we come together with your family or your chosen family or your support network that's with you? Can we go through some of the key elements together so that we're all on the same page? I know that we do have a lot of waste in the hospital system, the medical system, but this is one thing that I really encourage using paper for, is making sure that there are copies available to all participants. So anybody who is listed on the safety plan as a supportive person, we should really encourage them to have a copy of this. So whether that's mom and dad, and if parents are separated, I always make sure that we have a separate copy for each household, just to ensure that everybody is able to have a copy of this. If someone has a regular counselor, sometimes they'll say, like, if you don't already have a safety plan, would you like to bring this to your next counseling appointment? And maybe this is something that you can continue to add to. Working in the emergency department, I recognize that I'm not the long-term service provider, and so I always frame a safety plan as a living document. When you learn new coping skills, when you get new access to services, or when something changes, you want to make sure that you're updating this. And then also, when we talked earlier, Otto mentioned including family doctors and nurse practitioners and the primary care providers. So we want to make sure that they're included in this. Do they need a copy of that? Would that be beneficial for them to have a copy? So on all safety plans, we always do, in my own practice, regardless of what the concern is for the safety plan, I always make sure when we're in a crisis, sometimes we do things we wouldn't normally do. So having limited access to things that could potentially hurt us or hurt others is always the goal. So always thinking about safety. So I always talk with families and young people about medications being kept in the either locked up or in the appropriate locations, and only giving what is needed. So if they get a daily antidepressant, only giving them one pill, so we don't have a risk of overdose or some concerns with the medications. Sharps are kept in appropriate locations, so that includes razors kept in the bathroom, scissors kept in the common areas or the kitchen, knives and things like that. Cleaning products are kept, in the bathroom or wherever the cleaning products are kept. And weapons, this includes firearms. So I think sometimes when I talk with healthcare providers, well, they'll say, like, well, in Canada, we don't really have guns. Like, most people don't have guns. I personally don't know anybody who owns a gun. But at the same time, this is something that is a common concern when you think about people who hunt in their free time, and family members who are possibly involved in police work. So we always want to make sure that we are talking about firearms, because we know about the lethality and the risk associated with that. So we always want to make sure when we're talking about guardrails and protective factors, we always want to be assessing future orientation. So what are you looking forward to? What is something that you can take away from the safety plan that might be worth keeping you here, depending on what the concern is for the safety plan? And this also brings together like a strengths-based approach when you're completing the safety plan. There are things that are going well for you, and we want to highlight that, right? And so making sure that we're identifying those strengths. Providing education on distress tolerance and emotional dysregulation. So there's a lot of really great resources out there. We have some listed at the end of our presentation. And this isn't something that has to take a lot of time. One of the things that I do in the emergency department is talk about utilizing ice and temperature. And it's something that's really easy because we have a great water machine and an ice machine, and I can show them right in the ER. So what is effective in your area and what is feasible in your own area? We also always want to make sure we're including cultural or spiritual practices or beliefs. So if attending church or attending certain community services are really helpful for that person, we want to make sure that's included on their safety plan because that's something that they find beneficial for their own mental well-being. When appropriate, we do want to make sure we're including harm reduction education and resources, and this can be complementary in addition to the safety plan. So I'll go into that on the next slide. So a harm reduction approach a lot of the time is associated with substance use, but we actually can use a harm reduction approach in a lot of different areas. And one of the other areas that we often see this in is with self-harm. So it's important to consider using a harm reduction approach when completing safety plans with patients and their families to ensure that the options that we provide and the recommendations are effective and feasible. So to say to someone, we don't want you to overdose, so don't use drugs. We don't want you to hurt yourself, so don't cut yourself. We know that that's not a feasible option, and we know that these are coping strategies. So our goal is not necessarily to take away, but it's to encourage other options and learning new skills so that we can slowly start to reduce either substance use or self-harm in that way. So some of these examples are, and a harm reduction approach with safety planning is education and teaching with patients and caregivers on self-harm and substance use. Is there a situation where they're self-harming and they're requiring medical intervention? Can they come and talk with you when that happens? And with substance use, can we do Narcan kit teaching? Can we talk about naloxone kits, safe substance use supplies like clean needles, filters, sharps containers? Most emergency departments have access to Narcan kits. Some emergency departments and clinics also have access to safe injection and safe inhalation kits. And so I know in Richmond, they will have them all prepackaged and they're available on a cart. So anybody coming to the mental health center has access for them and they don't even necessarily have to ask, it's right there. At Surrey Pediatric Emergency, we actually have a safe injection kit that comes with a sharps container and it comes in its own little package. It's discreet in that sense. So is that something that we want to include and provide some education on? If they're not already connected to primary care, then ensuring that we're providing them with that information like a youth clinic or a local urgent care. If they want to do things like STI testing or birth control, that's also an aspect of harm reduction, right? Education and resources on safe sexual practices as well. So condoms, STI, and pregnancy. When we're talking with young people and looking at it from a holistic approach, I find maybe they're not interested in talking about their substance use today or their self-harm, but there is some other aspects of their care that they are wanting to get support in. So that's important to make sure that that's provided. So just a note here, and we did talk about this briefly in our family-centered care module, was that if a patient does not consent to disclosure about their substance use or sexual activity with caregivers, blanket harm reduction teaching can still be done. So a lot of the times when it comes to Narcan kits, I'll phrase it to parents that I do this with all young people, given the toxic drug supply right now, or if it's something to do with like condoms or STI testing, this is always something I offer to all my patients. So it's not just your child. In order to maintain that confidentiality and privacy. So when we're identifying protective factors or guardrails in a safety planning situation, part of creating an effective safety plan is identifying those protective factors that may either prevent or reduce the risk of a patient harming themselves. So protective factors are a way of instilling hope like previously mentioned, it takes a strength-based approach and it builds on those protective factors. So an example that we've heard from young people of protective factors are either not wanting to hurt their family, maybe they're working towards a goal, maybe they want to become a school teacher, or they want to travel and they want to go to Japan, some things that they're looking forward to or things that are future oriented. So when we're talking about future orientation, it's really important to identify that. The risk is higher for someone who either doesn't see a future for themselves or doesn't see themselves in the future. And so we do always want to be ensuring that's part of our safety planning. And then once we understand what their protective factors are, we can seek to build and foster them to help our patient work towards a life worth living. So in the emergency department, that looks like for me identifying something that they're looking forward to. And if I'm completing a referral, then that's included on the referral and that's included on their safety plan. It also offers an opportunity from something like our first module, which was working with young people, is an opportunity to talk about like their interests, what they're looking forward to, what keeps them like here and what they want to do with their lives. So I think that opens an opportunity for engagement and rapport as well. So an example of a way to phrase this when you're talking with someone is, despite how hard everything has been, what is something that's keeping you here or has led you to not giving up yet? And sometimes what I say is like, what are you looking forward to? What's coming up for you, or what's down the road for you in a couple years? What do you want to do when you're older? Those kind of things. So some examples of a safety plan, we do have a link to this. So this is actually the self toolkit used through Kelty Mental Health and BC Children's Hospital. It's actually a package. It's not just the one page of the safety plan. There's a lot of pictures. There's one for children and then one for adolescents as well. Obviously recognizing you may not want to use a children's safety plan with a 24-year-old, but I will say I do really like the colors and the way that it's laid out. So this is something that I would consider using for young people as well. Maybe just not the picture aspect here of the tools to feel better. There's a number of different pages, but you can link it. Will be in the link at the end. So this is just one example of a safety plan. And you can see that a lot of the categories that I listed in the beginning are here, including the crisis line information and some things when we're talking about protective factors at the bottom here. One thing I'm looking forward to doing. And it also identifies an important person in their life and something that they enjoy. So really taking a strengths-based approach when we're doing a safety plan with someone. Okay. So I will go into this case study here. I will read it out, but it's also on the screen here for you. So Edgar is a 16-year-old male who is currently in the emergency department for self-harm and suicidal ideation. His mom called 911 when she found him in his room crying, holding a knife, fresh self-harm marks on his arms, and voicing thoughts to stab himself with a knife. Edgar was agreeable to attending to the hospital with the ambulance, but is now feeling overwhelmed by the waiting process and is expressing frustration with mom, asking her to leave. The psychiatrist has seen the patient and spoken with mom. Edgar has been deemed safe for discharge with the urgent community follow-up arranged. You enter Edgar's room during this conversation between Edgar and mom. Edgar is demanding she leave before you discuss safety and discharge planning. So when we consider previous modules that we've talked about, so engaging with young people, as well as family-centered care and confidentiality, which was a topic that we discussed last month, these are a couple questions that may come up. So how would you start this conversation with Edgar and his mom? So Edgar just wants to go home. He's been waiting for hours. He just wants to get this over with. How would you start that conversation? So maybe we'll give people a couple minutes and you can either put your hand up or put it in the chat. And then some other questions here is, what information do you think Edgar would need to know about confidentiality that might make him more agreeable to doing discharge and safety planning? So from our previous education session on confidentiality, some of those concepts that we talked about, what might you use to engage with Edgar as well as mom and make sure that everybody is feeling safe to go home? We'll give a couple moments in the chat, and then Sarah and Otto, I'll get you to read those out. And if anybody prefers just to put their hand up, that also works.
And for those who haven't been to any of our previous education sessions, we always record them and have the slides. And so if anyone hasn't gotten access to them, feel free to, our team email will be at the end of this, but if you're ever looking to access some of our previous education, you can reach out anytime.
maybe a bit of a plug for our Teams site as well, which is linked in all of our emails, and we're happy to send that out when we send out the slides for this presentation as well. So we do try to keep that as up to date as possible. So any thoughts from the group on how you would start this conversation with Edgar and his mom, and what aspects of confidentiality would be helpful for Edgar to know prior to having this conversation? Oh, I see a hand up. Fiona, go ahead.
Hey, one thing that, and I don't know if this is the thing I would necessarily do at the very start, but just one thing that I like to keep in mind with folks when tensions are high, because it sounds like a lot's gone on for these folks, is just where possible, like you can just validate their emotions. So start with a validating approach, because if Edgar's frustrated, wanting mom to leave, and also, but then mom's like, well, I want to know, like kind of there's limits to what we can and can't do, but just sort of providing some kind of like validation and maybe setting a bit of a stage for that conversation to come about things we can
Definitely.
and cannot do.
Yeah. And that's something we talked a lot about in the family-centered care module. Is a lot of the times in my own practice working in the emergency department, a lot of tension can be really easily resolved by just validating, like, it is really crappy that you've been here for 4 or 5 hours. I'm so sorry that you've had to wait. Like, this is like a new process. Edgar's 16. Maybe this is the first time that he's ever accessed any mental health care. And this can be really scary for both Edgar and for parents and family. And just really starting with that validating statement that we like, I can see that you want the best for Edgar. And it seems like Edgar would really benefit from talking one-on-one, but I'm wondering if we can come back together and talk together as a group so that everybody feels safe to go home. Given that Edgar's 16, one of the things that we talked about in a previous education session was the ages and confidentiality. So what is that information that mom would need to know to make sure that she can keep Edgar safe? So that's something that we always want to consider when we're talking about young people that are still living at home or really relying on their parents. So yeah, so definitely starting with validation. And following through with the request as well. So wanting mom to leave, like, we can have this conversation in private, but we do want to ensure that certain aspects mom is aware of. Can we talk through that together? What would you be comfortable with mom knowing? So maybe Edgar just doesn't want to have mom in the room for this process, but he's totally okay with her knowing everything, or he doesn't want her to know anything. And so having that conversation about what the limitations of confidentiality are, what information do we have to share to ensure that he can be kept safe by mom, and what information maybe Edgar can provide to mom at a later time if he's feeling overwhelmed in that sense. And so some of the things that would apply to confidentiality is like, what does mom need to know? And what would be required for continuity of care purposes. So if mom's going to be caring for him in the community, how is she going to do that? And as well as what information is going to be shared with the team that he's going to be referred to in that information. And as Sarah said, that presentation was recorded, and we do have access to the slides on our team site. And I already see a couple people have requested, so thank you for that. And we're happy to share that information out as well. So we're going to move into transition
So
planning. So I'm
Steph,
going to,
just before you move on, Aiden had
yeah.
some really good thoughts in the chat if
Oh,
you
okay.
didn't see
Sorry,
them.
I can't see the chat. Sorry about that. Go ahead. Can you, one of you read it up for us? Yeah.
Happy to read them out. So Aiden, many of you might know Aiden, but he works really closely in the patient engagement world, which is such an important area with families and patients. So he was saying his non-clinical patient engagement view, use mirroring. Example, you've been here a long time. It must have been tough coming here by ambulance. And then just pause, see if Edgar says something. Aiden also said, Mom, you've surely got a lot of information to provide. Can I check in with Edgar and then circle back to you to form a complete plan? And his last comment was, has Mom had food in the last couple hours, a drink, give parents an out to take care of themselves?
Definitely. And that can be so important, especially when you know that the wait is going to be long. Is there something, hey, can I grab you something to drink? I'm going to come see you. I'm just in the process of doing something right now. Can I grab you something to eat? Especially, like I said, if you know the wait is going to be long. And this is specific to the emergency department. In community care, this would likely be an appointment. And so we can still offer some of those things as well, too, just to make them more comfortable with the process and answer any questions that they have. Great. Thanks for that, Aiden. If there's no other comments in the chat, then I'm going to hand it over to Sarah, who's going to talk about transition planning.
Yeah, thanks, Steph. So this is the last major section of our education today. It'll be around transition to adult care and transition planning, and we'll talk a bit about resources and resource connection at the end. So why is transition planning important? We know that any service transition, but particularly that transition from child and youth to adult mental health services, it's a really vulnerable time for emerging adults in that health system. The highest rates of service disengagement occur in this age group, so people dropping out of services and being unattached. We also know that psychosocial and brain development continue into the mid-20s, right? Around age 25 is when our brain finishes developing. And so while they might be considered legally an adult and moving to a new system, they're still, in a lot of ways, requiring a lot of really youth-friendly care and potentially special considerations than the rest of kind of the cohort in adult services. And that can further be impacted by developmental disabilities, traumatic events, substance use, and mental health. So some of the big things we see with complex case consults with someone transitioning might be like neurodivergence, so maybe autism or ADHD or FASD combined with things like mental health, substance use, family burnout, right? And really, how can we support this family and this young person when they transition to that new system? And we know there's a significant difference in service offerings and expectations of independence between child and youth teams and adult teams, right? One of the common things we hear from teams is that in the adult mental health system, it often moves to more of a case management focus, versus in the child and youth system, it tends to have a lot of access to counseling, wraparound supports, like things like OT or outreach. So again, very, very different offerings often. And they're already undergoing so many other transitions during this time, right? Finishing high school can be really jarring for young people, especially if they had a lot of supports through there, like a school counselor, or were accessing extra supports for learning. Losing MCFD supports, right? When someone turns 19, they're losing a lot of funding, potentially losing housing. They're also looking to be increasing their independence. So just, it's like there weren't already enough transitions and our health system gives them one more, right? Next slide. It's also important to be aware of how discharge or transition can lead to increased anxiety and feelings of rejection for youth. I'm sure a lot of you are nodding and listening to this, but this can particularly be true if a young person has had a history of unstable supports, and now they feel they are losing one of their key sources of stability. So we might see things like a young person acting up a lot more, getting more symptomatic, in the month or two before discharge, because feeling a lot of that anxiety and really mixed feelings about losing this support system that's felt really safe for them. So many of you might have heard of SAGE. So we know that for decades there's been criticisms that when young people are aging out of MCFD or government care, it's a really, really steep cliff that they get dropped off when they turn 19. And so MCFD has developed a program called SAGE. It stands for Strengthening Abilities and Journeys of Empowerment. I won't read through everything on this slide, but some important things to talk about are the eligibility, which has been expanded. So it would be a young adult who has spent at least 24 months or 2 years in government care between the age of 12 to 19, regardless of their legal care status. And they can be connected with SAGE from age 19 all the way up until 27. And so if you have a teenager who's had some involvement with MCFD and you're not sure whether they would be eligible, it is never like there's no harm in just reaching out to MCFD and inquiring, because you might be surprised sometimes about whether they could qualify or not. It's also important to start that conversation early so that there would be time for MCFD to get that set up. Did I just hear someone wanting to ask something? Thought I heard a, but I might have just made that up in my head. But if anyone did have a question or a comment, feel free to raise your hand or unmute and let us know. But again, with Sage, there's some great programs around. There's a transition navigator who helps to case manage and support all their services. They might have access to more ongoing funding to support with things related to housing, things related to building life skills, vocational, mental health counseling. So definitely a good resource to consider for any of your clients who have been involved with MCFD. So with transition planning, key elements. So sounds so obvious, but start planning early, right? In short-term settings, some of you might be attending today from the emergency department, from an inpatient unit where you might only have someone for a few weeks or even a week or a couple days. So in a short-term setting, just as soon as possible, right? Discharge planning starts upon admission. We really start looking at conversations with family and young people. In more long-term settings, so say you're on a child and youth team, or maybe you're on an adult team, I would say at least ideally 6 months to 2 years before aging out. There's no such thing as too early of a time. We know with some young people with medical complexity, conversations start around age 14, 15, just really starting to plan and help them build independence over those last years. And again, it depends on complexity, right? If someone is really complex and we're a bit worried about their needs being met in the adult system, we want to start that transition planning and support and building their independence as early as possible. In terms of each person, it looks so different. So that's why making an individualized plan is great. So there's a questionnaire called the Transition Readiness Assessment Questionnaire, or TRAC. If Steph presses the next, there's a little example of some of the questions. So it asks a young person things like, do you contact the doctor when you have a health concern? Do you make or help make medical decisions pertaining to your health? Do you attend your medical appointment by yourself, or at least part of it by yourself, right? Or are parents still attending? So this questionnaire is really helpful because it identifies goals for improving independence that they can then work on. There's also a resource we share later on in our resource section. It's an app made by CanChild, so it's a free Canadian app called the My Transition app. And it also has a transition readiness questionnaire embedded in it. And then youth can actually use that app to track things like, when are their appointments? What are the names of their healthcare providers? They can keep some of their medical information in there about medications and things. So if their healthcare provider asks, they can open the app and know where to look for it. So some really great resources to start introducing and working with the youth on when they're still in the child and youth system. And then in sessions, starting to assess their motivation and understanding, right? So I always like to ask them to share back what the plan or the session takeaway is to make sure we're on the same page and make sure that they're understanding the goal that we had come to. Also, what they know about their medication. Are they the ones that know their dose? Are they the ones that take the medication, or are they getting support with that? This can really help us better assess their insight and function and determine what we might want to work on with them in preparation for transition to adult care. Involving the client, family, and other relevant stakeholders. So we talked earlier today, a lot of our things around discharge planning and safety planning applies to transition planning as well, right? But if they're lucky enough to be connected to primary care, having a GP or NP. We do know that if a young person is in an area with a Foundry, there are primary care networks at Foundry. And again, that allows a young person to be followed up until the age of, I believe, 24 or 25. And so that might be another bridge if they're not connected to another GP or NP in the community. Each Foundry site has kind of different wait lists in terms of what that primary care service offers, but it's been a really amazing service for young people to get more access to primary care. And then sending and receiving clinicians, right? Are we able to have that sending team make a bit of a transition plan with the receiving team in the adult system? And identifying potential receiving teams and supplementary resources or services. So one of the things we hear the most often is a child and youth team is helping to make a transition plan to the adult system. And there's not like there's a mirrored team in the adult system that looks exactly like what they do that's for a higher age group. Services can look quite different. And so what often ends up happening is a lot of really creative splicing or combining a few services together. Maybe they're getting some groups through Foundry. Maybe they're doing some things through an adult mental health team. Maybe there's also a support worker coming in because they have CLBC funding. So it can look very, very different, and often a few services combined together might be able to more meet the need than what was offered within one team in child and youth, because we know that it can look quite different in terms of how much wraparound there is.
And Sarah, just to acknowledge a couple of comments in the chat. So Fiona mentions that can track be used in an adult population as well, if we know. So I'm not sure if it's used in an adult population.
I think in terms of, if you went to the website, I think the researchers that developed it would likely have that information. I'm not sure off the top of my head, but if you're using it just kind of in a clinical setting to inform goal setting, I think there's no harm in, say you have someone in the adult system who is still having a lot of challenges with managing things independently and building life skills. I think it would definitely be helpful to be able to use a tool like that to be able to then build their goals. I think the original design of it for the track questionnaire, as well as the on track My Transition app, was designed to start kind of around, 12, 13, 14, sometime before age 19, but I don't think there'd be any harm. Was there another question?
Uh,
And we do have a link to track in the resources at the end as well as the CanChild app.
Yeah, that's the one I posted. Apparently it's broken, the one from our resource section. But someone else posted an active link, so thank you for that.
Oh, great.
It's
Thanks
from
for flagging
Brett.
that for us.
And then just a couple of brief comments from Aiden. Thank you. That he mentioned, if working, that the young person might have a junior position, often in shift work in areas like retail and food services. And yeah, understandably, they might lack schedule flexibility. And then the other comment Ada makes is to maintain goal-oriented approach that focuses on youth's short-term identified priorities. Often in adult health, we talk long-term, and this can be overwhelming to young adults and youth. So really valid points there. Thank you, Aiden.
And I see Aiden's most recent comment. Young adults often share, although they may be legally an adult, they often resonate with older adolescent tools still more than they do with adult tools. And also adult mental health can lack technology tools at the same design quality and feature functionality. Further reason to tap into the tools. Yeah. Stefan Otto and I were having a great conversation last week about like the idea of youth-friendly spaces like Foundry or places like BC Children's, where there's lots of bright murals and things like that. And we were just saying, this might be designed to be youth-friendly, but I'm pretty sure people of all ages benefit from environments that are youth-friendly, right? I think we all benefit from beautiful colors. We benefit from really inviting spaces, bright windows. And so even if you're in a fully adult team, like making changes like that will benefit people of all ages. And so I think us moving away from thinking that youth-friendly things are only for youth, because I think everybody really benefits from them. Exactly, Aiden, like a universal design approach. So in terms of some other key elements, so before the transition, providing support. So providing the client and family education and peer support on what to expect in the adult system and how services may differ. So some of you on the call might be from BC Children's Hospital. So we know about Kelty, which is a really amazing resource hub. They have family peer support workers if caregivers call in and chat to people. And it's a lot of caregivers that have had to navigate the system themselves. And so it's a really great resource for parents or caregivers to be able to call in and get that support. We also have that, as well as Family Smart, that are linked in the chat at the end. Just the value of peer support around this age. I know we had Natalie, a youth peer support worker, joining at the start of the call. So the value of youth peer support workers and others in settings that can support with this. And shifting from a counseling to a case management focus. We know this is one of the biggest barriers for young adults is when they turn 19, are there still places where they can access free counseling that is faster than just like rather than faster. Either there could be a wait list, or it might be a very short-term counseling offering, and then harder for them to find ongoing long-term counseling unless they have benefits or the ability to private pay. And so that's a barrier that teams all around BC are seeing and looking to improve for them. There's also a great workshop through St. Paul's. So some of you might know St. Paul's. They have a program called the Scotiabank Transition Program. It's based out of St. Paul's, but it's available for anyone across BC. They have in-person, but also lots of virtual groups. And these groups are designed to support young people and their families to prepare and get ready for a transition to adult care. These workshops are not mental health specific. They can be for someone across any health diagnosis. So it could be a young person with medical complexity, but it could also be a young person with mental health or substance use. So it's quite relevant no matter what a person's diagnosis or services they're accessing are. And we have that linked at the end as well. And then discussing their rights as a consumer of services. Part of this, we talk about a lot of the, it can feel scary transitioning someone to adult care. It can be anxiety provoking for the young person, but it's also a really neat opportunity for them to feel empowered that they are getting to take charge and manage their own care. And for some of them, they may be excited about this and just needing a bit of support to feel like they're confident in doing so. And then, where possible, gradually reduce the frequency and degree of supports leading up to the transition to adult services. The reason I say where possible is we know sometimes there might be a 18-year-old going through complete crisis, right? And so, of course, it wouldn't be ethical for our team to be pulling back and seeing someone every 2 weeks if that family and young person have really high needs and some really challenging things are going on. But where it is possible with a client's presentation, can we talk to them and say, hey, over time, it may be helpful if we have our appointments a little less often, or we start having you come to appointments on your own, or let's start practicing these things and gradually reducing how much support to help you prepare for the fact that the adult system will have less overall supports for the most part. And some things for that might be strategies to remember appointments. Maybe it's if a caregiver comes to most appointments with them, they start where maybe the caregiver's in half the appointment and then leaves and they have the rest of the appointment on their own. And then over time, they do that entire appointment on their own. And advocating for their own needs and appointments. There's another great workshop. I believe it's through Recovery YVR, again, free virtual, but the workshops are called Talking with Your Doctor. And it's a great resource for youth and young adults, but people of any age in just learning a little bit more about how to kind of advocate for themselves in an appointment with the doctor for mental health and substance use concerns. I believe that's linked at the end, but if it's not, and I know there's some folks here that use Recovery College YVR a lot, feel free to throw that link in the chat. Supporting development of life skills. So I'm an occupational therapist by background. So any OTs on the call or clinicians on the call that have OTs on their teams, occupational therapists, support workers, peer support workers are really great people to get involved around building life skills. Can there be things like transit training, like education about managing finances, or starting to get ready if they want to have resumes or start considering work interview practice. And life skills can happen through groups, through family involvement, through one-on-one if you have capacity in your setting. And there's also lots of online courses and resources, which we'll link at the end as well. And then when needed and where possible, provide warm handover to a new service. So we know this might not be feasible in all settings, but if you're able to actually go with that young person to check out the new team and the new service, and they can actually go and see what the building looks like, especially if you might have a neurodivergent client or someone with a developmental delay where transitions and change are really, really tough. Anywhere you can bridge that gap or help have a bit of a warm handover so they know what to expect. So I know some clinicians will even have a meeting with the sending clinician and the new clinician with that young person so they can all meet together and the young person can feel more comfortable. And then after transition, so now we've transitioned a young person into the adult mental health system. So where able, we know that, we just talked a lot about how can we prepare a young person and their family and really send them over in the best way. And then on the adult mental health side, that's the side that's catching the ball. And we're also wanting to provide them a warm and kind of a soft landing. And so we know that adult mental health teams often have big caseloads, a lot of just kind of constraints within the system, but where possible, just recognizing that when a young adult comes into an adult team, they might need initially a bit more support or a little bit more time, and you can gradually reduce this with time. But where possible, really meeting them where they're at. We know that a 19-year-old might not be functionally an adult in a lot of ways. And so how can we meet them where they're at and understand what their needs are? And we can support continued development of life skills. So I'm a huge cheerleader of life skills groups or life skills supports in both child and youth teams and adult teams, because at any age with mental health and substance use, we know how important life skills are for a person building their independence, particularly things around housing, finances, school, or employment. And then supplementing with other community or private pay services as needed. So as mentioned earlier, sometimes in the adult system, it does look like it takes a village, right? It might be a few services together to be meeting someone's needs. And I'm just seeing a comment in the chat. KHP also, oh yeah, is that Kelty, Aiden, or what's KHP?
Kids Help Phone. Kelty, of course.
Oh, Kids Help Phone.
Yeah, as we're all BC people. But if they're looking for additional resources, and you haven't checked out the Kids Help Phone's website in a long time, their website is incredibly extensive, and sometimes will go a little bit broader than topics on like Kelty and things like that.
Thanks so much, Ada. I actually didn't know about that, so I'm really keen to look into that. And I really appreciate you mentioning personalizing these resources. So in our last bit of today, we will talk a bit about resource connection, and that's a big piece of feedback from young people and from families in the focus groups and engagement we've done is rather than just giving someone a handout, can we actually sit down and talk with them about what makes sense and then really help to personalize resources for them? Yeah, and then especially in the emergency department, folks have a lot of things to remember. It can be really game changing to actually sit down with the person, have something written down, and really personalizing that recommendation. Yeah, thanks, Aiden. So this is our last case study of this education session today. So I love that Steph picked the name Gertie. I don't think I've ever met anybody named Gertie. But Gertie sounds more like an 80-year-old, but in this case, Gertie is an 18-year-old female that is turning 19 in June 2025. She is currently connected, yeah, so June 2025, so that's in about 2 months. She is currently connected to a child and adolescent mental health community team with a case manager, OT, peer support worker, and attends a local youth clubhouse where she participates and volunteers once a week for events. Gertie has a diagnosis of social anxiety, depression, and ADHD. She is currently taking medication for ADHD and depression. Gertie has difficulty organizing herself, planning, and has increased anxiety with changes and needs time for transitions. Her parents are somewhat supportive with getting her medication and 2 appointments, but she has a younger sibling with cystic fibrosis that takes up a lot of their time. So what are some of the challenges to foresee with Gertie in the next 6 months? And what I might do is I might just actually pop this question in the chat and have us move back to this previous slide so you can reference it. So for this one, what I might do is I'll see if people want to start with a chat blast, and then from the chat blast we can unmute and do more discussion if we want. So with the chat blast again, just typing and drafting your thoughts in the chat and just not hitting send yet. And I'll give about 30 seconds for people to write some thoughts, and then we'll send them all in a blast. So what might be some challenges that come up for Gertie with transition to adult care? I'll give folks about 15 more seconds. Okay, feel free to hit send. So some challenges from Kelly, meeting new team and this transition may cause increased anxiety for Gertie. Yeah, especially if social anxiety is one of the things Gertie's dealing with, definitely. May take her a lot of time to build up trust and rapport with a new team. Missing appointments due to struggles with organization, totally. And we know in certain adult teams, there are policies where, if there's a certain number of missed appointments, a person might get discharged, right? So there might be a little bit less tolerance for flexibility and for no shows in the adult system because they do have long wait lists. And so, yeah, that would be, again, one of the reasons that some young people might end up disconnected to a service. And Brett, coming up fast on the transition, need to start that plan in advance to reduce the anxiety that is likely to come up. Totally. We talk about the adaptive side of anxiety, right? I'm sure some people on this call can relate to when you're feeling anxious about something, over planning for it and prepping for it is what helps reduce the anxiety, right? And so how can we let Gertie be involved in this and help her know that there's a plan? Um, the increased anxiety will likely make it difficult for her to make her appointments with the new team. Yeah, Faith, definitely. It would be good to discuss the plan of transition in advance. So this might be a client where that warm handover or really bridging between the two teams so she has time to know that new clinician might be huge, right? And really make the difference for Gertie with her wanting to engage. And with Fiona, support inside the family may be limited due to a sibling with possibly high medical needs. Gertie might rely heavily on her youth resources. Definitely. And I think there's a word for this. Isn't it called is it called the forgotten siblings? But when there's a young person that has a lot of medical complexity, sometimes that other sibling can internalize or feel a little neglected because the parents understandably are spending a lot of time taking that older sibling to appointments or making sure to meet some of their medical needs. And we sometimes will see enhanced, like we'll see more mental health symptoms showing up in that other sibling in relation to feeling a bit of that neglect or not feeling like they can go to parents because the parents are stressed out and dealing with so much already. Any other thoughts, or does anybody want to unmute and talk a little bit more about anything that's coming up for them or some things that they might think to do?
Just keeping in mind that ADHD meds can be expensive and Gertie's transitioning to adult. So does she have a care provider that's going to stick with her as she transitions into the adult system, who can do regular prescribing, is comfortable prescribing ADHD medications because she might be on stimulants. ADHD care in general, vastly different in adults, mostly switches to limited supports with a dominant private fee-for-service, given Gertie's complex family situation with a sibling who also has complex health needs. Does she have access to resources to access those sort of services? Or is there nonprofits or things like that in her community that she can be connected into?
Mm-hmm. Absolutely, Aiden. I know you always when you give a comment, you always say, "Oh, I'm non-clinical." And sometimes I wish you were clinical because I feel like you're always spot on with just yeah, with a really good sense of being in tune with the family and with the young person.
I'm married to a pharmacist and I take ADHD medicine, so I have strong lived experience.
Perfect. If there are no more comments, we will keep moving. So some other potential ones here, a lot of you had highlighted that increased anxiety with a looming transition, ability to manage and integrate new routine related to difficulty organizing and planning. So likely needing some support with that. Ability to integrate new information. So things like location, appointment days and times. I think a lot of us on the call know that with anxiety, it can make it really hard to pay attention in the moment when our nervous system is really ramped up. And so memory and attention. And so making sure that things are written down or that if she's really stressed out in an appointment, there's a way where she can access the information later because she might be trying to listen in the moment and having a harder time remembering it later. Receiving less hands-on support or follow-up, that culture of adult care services, and then exploring limits, right? When Gertie becomes an adult, she might see herself as an adult and refuse services or think she doesn't need them. And And there is a bit more of that ownership of a young person making decisions for themselves, right? So for all of the education we do, we work with young people as well as we work with families and caregivers with lived experience supporting young people with mental health or substance use. So just highlighting some key feedback that I think Aiden already highlighted really. Actually, the next slide will touch on some of the things Aiden said, but we first want to just know that a lot of families have probably tried a lot around resources and strategies. So rather than just giving them a list of things, actually checking with them first, what's worked, what hasn't worked, and building on the strengths they already have. So one of the caregivers we talked to, I loved when she said this, but she just said, the best thing to hear is when a clinician says, hey, you're doing a great job. What do you need? Or what are you hoping to achieve? A caregiver will often have a good sense of what they need already, or a young person might have a good sense of what they need already. And it can be discouraging to just be handed a pamphlet or told about a website, right? So as Aiden said, wherever we can, actually walking through a handout or resources with them. I like to circle things, put notes on them, put stars, and personalize them when possible to meet their needs and actually talk through with them. Like, does this service seem like something that might make sense for you or would be helpful? Like, would it be a feasible thing for you to go to? Ensuring patients and families have received education on their diagnosis and treatment and help correct any misconceptions or concerns they might have. So this could apply to anything we talked about today, right? Discharge planning, transition planning. Sometimes we might have someone show up to an outpatient or community team and they got a diagnosis in hospital, and then when you ask them what they understand about the diagnosis, they still kind of feel like they don't have a good sense of what the diagnosis means for them, or sometimes the family isn't sure. And so how can we correct any misconceptions they have, especially in the era now with TikTok and social media? We know that it's letting people talk about mental health a lot more and connect with communities, which is great. But I think there was a stat about the amount of misinformation on TikTok around mental health, and I think it was something like more than 50% of the information wasn't accurate. And so really just checking in with them and making sure we can give them accurate information or link them to evidence-based websites if they are wanting to learn more. And if there's any key coping strategies or resources we've worked on with them, ensuring these are written down so that the young person or the family can reference them later. And developing resources or understanding resources. So we know that many of you work in different settings and some of you might be really strapped for time and busy. And so there are lots of existing resource lists out there already. Aiden had mentioned the Kids Help Phone has lots of great resources. Some of our favorites here too, Indigenous Patient Navigators and Discharge Liaisons, Family Smart for caregiver support. They also have some great groups. Family Smart has an excellent group if a young person has been admitted, or of any age, I believe, has been admitted to the hospital either on an inpatient unit or to emerge for mental health reasons. There's a specific family support group to support the caregivers and family about processing this stressful period and how they can work with safety planning and things once they're discharged, like completely free virtual resources through Family Smart. BC Schizophrenia Society provides service navigation support to family members of those supporting anyone with severe persistent mental illness. So not just schizophrenia, it can be any mental health condition. Kelty Mental Health, we've talked about them a lot today. They have a lot of great resources on there around medications, about different diagnoses, about treatments. That's one of the go-to ones that I'll send to a young person or family. Supporting Families is a really great service that's Richmond specific. And then Here to Help BC. Working in interdisciplinary teams too, your team or your coworkers might have existing resource lists they've developed, and you might have actually worked somewhere for a while and not even realize that some of these exist. And so I find it can be really helpful to just talk to other people in my team to understand what they're using. And some coworkers that have worked in the system for 10, 20 years might have this awesome resource list they've built over the years. And so just working within the strengths in your team. Many other websites like Pathways, Child Health BC, Autism BC have lots of great resource lists and websites. Our team, the Missing Middle program, we have developed some resource lists for clinicians on such topics as housing, family resources, and substance use supports for youth and young adults aged 16 to 24. You can access these on the Missing Middle team site, which is linked in all of our email signatures. And I believe we've linked it at the end of this presentation in the slides you'll get. You can also just reach out to our team if you're interested and you want us to send you the link for accessing our Missing Middle team site. Our email will be at the end of the presentation today. And over time, you might actually decide to develop your own resource library. And many of you probably already have that. But in your own unique practice area, how can we have a go-to place so that over time it saves us time and we know exactly where to go for that resource? And if you are building your own template, this is just an example of what some templates can look like. Great. So just a quick summary of today. We went through discharge planning, and one of our biggest takeaways is that discharge planning starts from admission. Safety planning, we know that individual safety plans are needed, and ensuring harm reduction approaches are used. This can be really, really effective for not only substance use, but also self-harm, suicidal ideation, and other things as well. Sexual activity, things like that. Transition planning, we know that transitions are more effective when they are planned. So lots of resources were talked about today. Resources, and we can go to the next slide. And I'll pass things back to Steph just to walk through some of these resources.
So most of these we've talked either throughout this presentation, but we do just want to highlight some of them. So the self toolkit was the safety plan that I had a couple images from. So as previously mentioned, there was one for children as well as one for adolescents. So that can be a great resource if your team or department doesn't currently have a safety plan. Help for the Hard Times is a specific workshop through Family Smart. And another service this is specific to Richmond is that Richmond does have a central intake. So instead of trying to figure out what team will best meet the needs of your client that you're referring, they do have a central intake office that does look through and triage the referrals and get them connected to services that are appropriate for them. There is some fact sheets here that are available for transitioning Aboriginal youth with mental health disorders. There's also, we did highlight as well the SAGE program as well, which will be linked in here. We do have the suicide risk assessment guide was cited on here as well, and Compass BC. For those of you who are not familiar with Compass BC, it's a BC children's program that is available for healthcare providers that are providing care to anybody with mental health concerns and substance use concerns under the age of 25. So if you have questions about treatment plans, medications, anything, you can access Compass BC as a healthcare provider. We have some resources here on transition planning. So Sarah mentioned, I believe, all of these. So the transition app, the track questionnaire is linked here. We'll update these links for the broken one. For that, SAGE is on here as well. There's an autism training module for transition into adult services. BC Children's Hospital also has a transition to adult care checklist. And then Sarah did also mention the Scotiabank Youth Transition Program through St. Paul's Hospital. And then there are some life skills development resources here as well. So managing money for young adults. So that's through Open Learn. And some more financial and nutrition and healthy eating services. There's a Foundry work and education program. So if you have a local Foundry in your area, this might be something that is an option for clients that you're taking care of. And then I see here there's a Richmond specific one, Adulting 101, which is a group offered through Foundry and Integrated Child and Youth Services. So the contact information for Ali, who's running that, is here as well. And
Ali
Sarah,
has also been Ali's also been a really great resource for other teams wanting to start an Adulting 101 type group or a life skills group. So her email's there as well if anybody wanted to get in touch to understand more about the things that she covers in it, because it's been a really successful, pretty popular group being run. So.
And then so we also have a post survey here. So that's the end of our presentation. So we'll give people a couple minutes to scan the QR code. You do have a chance to win a Starbucks gift card. So for any of you who attended previous education sessions, we are in the process of sending out those Starbucks gift cards, and we really appreciate any and all feedback. We were able to implement some of the feedback from our previous education session into this one. And so we really appreciate you taking the time to complete the survey, not just for our data and advocating for our program, but also to understand what your needs are and what education you'd like to see, and if there's things that we can be improving on. So we really appreciate you taking the time to do that. So we'll have the last 5 to 6 minutes for you to scan the QR code, and Sarah and Otto will also post the link in the chat. And if you do have any questions, please feel free to comment in the chat, or even just unmute yourself to ask any questions that you have. And if not, we have 2 more education sessions. So for those attending today, we do have this entire session is actually split into 2. So we'll be hosting tomorrow during lunch hour, 12 to 1, an education session on discharge and safety planning. And then on April 23rd, from 12 to 1, we'll be hosting the second half, which is transitions and resource navigation for the month of April. And then we will be sending out dates soon for May's education as well. So keep your eyes peeled for that. But if there's no questions, thank you everyone for attending. And we really appreciate your engagement and responses and the discussion as well. So please don't hesitate to connect with us by email if you do have any follow-up questions, and we will be sending out the slides and the recording as well. And it'll all be posted on our team site. I think that's everything, Sarah. Am I missing anything?
Yeah, and just to be super clear, if you attended this full education session today, then the 2 lunch and learns this month are covering the same content. So don't worry about coming to the other ones this month. You've gotten all the content. If you missed a part of today, either the first or the second half, it's a great chance to come again to one of the lunch and learns to cover any of the content you might have missed.